I've heard and seen personally 1 or 2 questions that might show up from these kind of talks. And so once again, not super high yield, but enough that you should be aware of the concepts that are being tested, and I'll try to hit on those concepts. I find it interesting. The FDA is super, super helpful and good in the United States to take care of us and our patients, but they also put a lot of restrictions on us, which makes our technology sometimes less advanced compared to our European colleagues, where they just don't have as many limitations. And so this is a great example of, I think, is just highlights that image that the first laser built in the United States was actually by people that saw what they were doing in Germany, and it wasn't allowed in the United States. And so they just ordered all of the parts from the laser in Germany separately and then put together in the United States. And that's how we started doing laser in the US for intraocular surgery. And so the first lasers were done with xenon gas and our carbon arc, but now so this is what those historic photos actually look like. The laser burns are very large and asymmetric and atypical, but now, thank goodness, from advanced technology, we're able to pinpoint and provide a little bit more discrete care. So I've seen this or heard this showing up. So what does laser stand for? You should know this acronym and what that is referencing. What are FDA-approved reasons to provide at least focal grid laser in the macula, and then how do we provide the laser itself? So there's different types. You can do it at slow lamp, you can do it indirect, you can do it endo laser. I think this is a highly testable, both using optics and or in the retina. So one or the two could easily show up on a test. You should know what's in the visible spectrum. You should know what wavelengths associate with what color, and which lasers we use that associate with which wavelengths. So we'll go through a few of those. When you're doing retinal burns, what is actually occurring? So that usually it's the pigment that's taking up the burn in the RPE, the melanin. There's choroidal melanin, and then there's blood hemoglobin. So pigment absorbs most of the laser, and so where that's happening is the pathology. So if somebody has blood in their eye, like a vitreous hemorrhage, it might alter which color laser you pick to give them treatment because of how it's going to be absorbed. And so I think those are the concepts that could be testable on your exam. And then just a clinical note, the intensity of the burn is related to the size squared. So be very careful, like when you're defocusing a laser. So if you're defocused and now your circle is doubled in size, you're providing more laser intensity at that time in that area. And so just be aware of those kind of things, that you should understand that there is a correlation depending on the size of the laser, and if you're in defocus, how much laser burn could actually be applied. What tissues in the eye scatter light? So the cornea, a cataract lens, especially in nuclear sclerosis, is more testable than a cortical cataract, and then a vitreous hemorrhage. Those tissues are going to cause problems if you have pathology in any of those sites before you get to the retina. So light is absorbed by pigment, as we talked about. So what is important for you to know? So in the lens and then in the macula, you have peak absorption and blue light spectrum. So I think clinically practice, if you were given a choice on a test, like blue light lasers are not recommended, because you're going to absorb into tissues that you're not necessarily wanting to treat, and you're going to cause more harm than good when providing that laser treatment. Blood hemoglobin has less absorption to red. So if you have a patient with a vitreous hemorrhage and they have a retinal tear in the periphery, you might pick a red diode laser that you have in clinic versus a green light laser, which is most commonly used. Argon green is a very common laser, but if you have both, I would pick the red one. The red light is less absorbed by hemoglobin. So I always thought when I was taking my test that if I see red, use the red. And so I think I've heard of that showing up at some point. So yeah, so red light is deeper, and so that's testable. So if you have somebody that's super pain, but you don't have a reason to use the red light, I would use the green. So the deeper the penetration of the laser. So if pain is a factor, I would tend towards more of the green, but not to the blue, to where you're going to cause more harm than good. A yellow light laser, and or what we'll talk briefly about, and this is where, once again, as we talked about, OCTA is new. micropulse laser is starting to show up. I don't know if it's starting to show up. I think it could start to show up because micropulse technology is starting to take place both in the retina lasers that we use. It's showing up in glaucoma lasers where we do MLT instead of SLT or argon laser in the past. So I think micropulse laser would be somebody that, or be something I would try if somebody had an option if somebody had intense pain. But I would move away from the deeper penetration lasers, which are usually your higher wavelength lasers. So the red is going to cause a little more pain than the green laser. So like I said, avoid blue. It's absorbed by your macular pigments. It's absorbed by cataracts. You should, most commonly, best choices green or red and or yellow. Lasers in that wavelength for retinal lasers are most readily available. These are the ones that have been around the longest. So you should know about wavelengths in the 500 zone of the different types of green. These are well absorbed, and it's a good overall choice. It causes the least amount of pain and is usually a very straightforward choice. So as I talked about earlier, there's above your 600 nanometer wavelengths, the krypton red or the dye red. These are the least scattered, the most absorbed, so they do cause a little bit more pain, and they cause a little bit deeper burns. And so if you're wanting something that's deeper, so you have an extrafoveal like subretinal neovascularization that you're trying to ablate, like that would be a choice to go with a deeper laser or a red laser. So these are the kind of things I think they would test you on for what laser choice to pick for a disease process. So knowing some of the principles I think are what's important in knowing about laser posterior pole pathology. In the most recent years, some newer laser platforms have come out. These are now, these are FDA approved, so I think, since we're testing on FDA approved things, I think you should start to be aware of these. But I don't think you need to get into the highlights of, these have FA and OCTs. These are helpful if you want to practice retina and clinical practice. These are very helpful because you can take an FA and OCT and then it mirrors to the laser, and so you can look at that while you're at the laser and treat the areas that are leaking. And so these are more user friendly, but these aren't really highly testable knowledge, I think, in my opinion, for what you should be studying. But just know that these laser platforms are starting to be more common, and they might start to show up on your test. So of the other ones, besides, I think red and green are your most common ones you should know to use, why you should use red. Most people use green, why you should not use blue. But there are other dyes that have been approved that are being used, and some people have reasons to use those, but I haven't heard of those showing up to where I think you need to go and read as much about them. What I do think is going to start to show up on your test, and I think I'm going to start to increase this more in talks in the future, is micropulse technology. And so with our conventional photocoagulation, when you push the pedal, as long as you have the laser burning, the power continues to increase and starts to cause thermal effect on the surrounding tissue and the melanin and release particles that are going to cause edema and heat shock proteins and things of that nature that can be helpful but also harmful and ischemic to the surrounding tissue. So the technology has advanced that we now have micropulse lasers to where inside the laser, the duty cycle is the key term that I think you would hear on a test, that the duty cycle is offset to where you're no longer having this power that continues to extrapolate over time, but there's periods of time where the laser is on while you have the pedal down, the laser's on and it's off, the laser's on and it's off, it's on, and it's still having the same effect of causing the thermal injury that you want without releasing the heat shock proteins and the other negative side effects of the laser over time. So this is being used in the retina and in like the trabecular meshwork with micropulse laser trabeculoplasties, with focal macular grid. The studies, because of anti-VEGF therapies, this is not being as highly sought after and studied, but there have been some studies in the last 3 years that have looked at micropulse laser for diabetic macular edema. And the results are usually equivalent to focal grid laser with conventional therapy, but you're seeing less side effects and less issues with scotomas and things of that nature. So I think over time, this could pop up on some test question about what's the best use of some laser platform technology, and micropulse is an answer. I think that you should know enough about that to probably choose that answer. So what other lasers are out there? TTT is, I remember going through, studying in residency, this is something you don't often see. So how many people have seen TTT? 1? Yeah, so this is like one of those things that you have to memorize because it could show up on your test, but what does it actually look like? It looks very similar, like the laser and the application to the laser is very similar to doing a posterior pole retinopexy. So it's not something wild that you think about when we treat tumors and cancers, that this is some apparatus. It's a very similar type of laser platform, but just the laser physics are different. And so this is usually a larger spot size. It's an infrared diode laser. Where do we use this? Most often it is with melanoma treatment. But we also use this in other things like retinoblastoma. But you think about tumors and cancers, TTT is an option for that. So this goes deeper. So you think about red tissue, or red lasers go deeper than green. This is diode laser, so the deeper nanometer wavelength is going to go deeper into choroidal tissue. So you start thinking about choroidal melanoma. You want to get through the retina to hit choroidal melanoma, but it's not going to treat all the way. So if you have a melanoma that's 3 to 4 millimeters, you're kind of getting at your max of how much this can treat. And so small tumors, think about TTT as an option of an acceptable treatment option for those kind of disease pathologies. The endpoint for seeing these lasers work is either just nothing at all or slight graying of the retina. So you're not looking for that white burn like you might see when you're doing a retinopexy and you're adjusting your size and temperature. You're treating this one area for 1 minute, and then you're moving on to treat another area for a minute, and depending on what your treatment plan is for that patient. But you're going to see some mild whitening, and that's pretty much it. As I talked about earlier, there's a sandwich technique of using this with brachytherapy, but also using it in conjunction with ICG, as the laser nanometer wavelength is similar to the absorption of the ICG. This can often have a dual effect of treating more effectively, and so you can use them in conjunction to enhance the treatment of choroidal tumors. I don't think that would show up likely on your test, but something you might be aware of. And then just the proposed mechanisms. It's different from your argon lasers of causing a retinal burn. What is actually happening with TTT laser? So you're inducing necrosis and apoptosis of the cells. It can be used for CNVs as it's inducing damage and thrombosis and sclerosis to a choroidal neovascular membrane that's deep, and you want to treat that. It does induct the heat shock proteins that you also see with other types of laser platforms like the red and the green lasers. And some literature, it talks about that it helps protect the neurosensory retina during the TTT, and so that you're having this go on for a minute. These heat shock proteins help support and protect the neurosensory retina that's theoretically above the area you're treating. I don't think that's going to be on your test, but it's stuff that we need to know about as we're trying to offer best treatments for our patients and other things that could cause harm or damage. So what else did you know about cold lasers, PDT? This I have definitely seen show up as testable therapies. So most commonly choroidal hemangiomas, PDT is a therapy option. Any type of PDT has been FDA approved for wet AMD and both occult and classic FA patterns. And so understanding a little basic concept of PDT I think is important for your exam. So first looked at for subretinal neovascular vessels, you're injecting verteporfin, and the photosensitizing agent binds to the LDE receptors, which is more common in a subretinal neovascularization membrane, so it collects more readily there. So when you apply the cold laser over that area, it then can cause and produce ischemia to the choriocapillaris in that isolated area as you apply the laser over the area where there's been a higher increase in the density of the verteporfin. So as I said, this is most often seen in AMD pictures or choroidal hemangiomas are the two common things that you're probably going to get tested on. Some complications, I think the number one thing if you're going to get tested on a complication of the laser or the procedure itself is the photosensitivity that occurs with the injections. So you have to warn patients just like you do with, it's similar in my head. I would think about counseling a patient when you start them on doxycycline. They have photosensitivity from this for probably 3 to 5, but I tell them 10 days to stay out of the sun. So that's it. Those are the basic concepts I think you should be aware of with lasers. I don't think you need to get into, I don't think they're going to test you on specific physics of lasers, but understanding how they relate to clinical practice and the wavelengths of the lasers, I think is testable for your written boards. Any questions on those? Okay. So anti-VEGF therapy. So this is a, I'm not going to get into the actual disease processes because I think that's where retina gets into more when you have certain, you have your lecture on diabetic retinopathy, you have your lectures on vein occlusions and different studies you should be aware of for those. This is more just to give you a basic understanding of the anti-VEGF platforms and how you should approach those and thinking about them for your exam. So what are the injectables? What can we offer as alternatives to lasers when we're dealing with retinal posterior pole pathology? Anti-VEGF is obviously has done wonders to our treatment options for our patients, and we're not doing as much with lasers, and so therefore I think this is going to continue because of how well it treats some of the issues in the back of the eye is going to continue to expand. So right now we have three FDA approved options, one off-label option, and currently there's 2 more options in phase 2 clinical trials for longer acting anti-VEGF therapy. So I don't think you need to know about those 2, but I think you need to know about the other 4, the 3 that are FDA approved, the 1 that is off-label, and how they can treat issues in the back of the eye. So what is VEGF? VEGF is an inflammatory cytokine. I think about proliferation of new blood vessels, that there's increased vascularity when it's in the eye, and that there's some inflammation related to it. And so when you're offering somebody an anti-VEGF injection, you're trying to treat those 3 things or prevent them from getting worse. And then we'll talk briefly about steroids and what that's related to, and the upstream effects usually relate to inflammation. So in your mind, think inflammation, steroid treatment, anti-VEGF, mostly related to these things of proliferation and permeability primarily, but inflammation, yes, there are some factors that are altered by your anti-VEGF injections. So what's the first that you should be aware of? The first is pegadricase, and so the trade name is Macugen. So this was FDA approved in 2004 to treat a single isoform of VEGF 165. This molecule, as it was created, is an aptamer, and so that's a word that pops up on certain things that you might be tested on. And so it's pegylated, which means that as it binds to the isoform, it lasts longer. And so these injections were FDA approved to be out to 6 weeks. And so it's going to last longer than your ranibizumab originally when it was FDA approved to last 4 weeks. But it only treats isoform 165, and the studies have found that it basically only stops the progression of vision loss and did not help patients improve visual function. And so this was the first anti-VEGF specific treatment that was FDA approved. So this is just a picture showing the pegylated form binding to the VEGF and pointed out. So the second one that was FDA approved, I believe in 2006 or 8, was ranibizumab, also known as Lucentis or Rufab. This is a pan-isoform protein antibody and has been recombinant humanized, so with mice and human recombination of DNA. The diagnosis has been thought to, you basically want to treat this as quickly as possible to improve the cost of delay. The thought is that the quicker we get the inflammation calmed down, the quicker the resolution. And we've actually seen when you started this in 2004, 2006, and 8, that you can improve vision. So this basically obviously took over the treatment of pegadricase. And very rarely, if ever, do people offer that treatment now that ranibizumab has been approved and is continuing to be used. It's FDA approved for AMD, diabetic retinopathy, CMV, branch retinal vein occlusion, central retinal vein occlusions, and myopic CNV. There's a slide I have that also we correlate or extrapolate to other things. So when you're testing for your oral boards, we don't have studies that say you should give ranibizumab for somebody has choroidal rupture with a choroidal neovascularization membrane from that, or from histoplasmosis. But we extrapolate data from our other studies where we have choroidal neovascularization membranes to say that they should likely apply to those scenarios as well. But know on your written test that it is FDA approved for these disease processes. So as I said, the biggest thing you should be aware of is pan-isoform. It has a higher affinity of binding to Avastin or bevacizumab, but a lot of our studies have shown that there's a non-inferiority. So there's some pros and cons between using the two, but I think overall in your test, you should just have some general understanding of VEGF in general. What is an anti-VEGF injection? What are the injections? How do they differ? So the biggest difference here is that it is FDA approved, it is pan-isoform, and we'll talk a little bit more. So here is bevacizumab, also known as Avastin. So the big studies in the CAT1 and CAT2 trials showed that it's non-inferior. So this is the one thing that I said I think you should be aware of, that it's not FDA approved. We do use it off label, but that you should be aware of it. It was first created FDA approved for colon cancer, but through lots of study and research, able to say that the side effects are just as helpful in the eye, and the cost difference is drastic to where we should be considering this as a primary treatment, or at least alongside some disease processes when comparing them to our other medications that can be given. So we're not going to talk much about the cost economics, because I don't know if, I think at some point the ethics questions of that will start to show up on the test, but I don't know, and I'll be interested to know and hear if you guys ever see something like that in the future. But for now, I wouldn't get into any question that relates to cost on your test. Is probably, they're probably not getting into that. I don't think that that's a discussion to be had on a written exam, but definitely something we should be talking about, at the academy and other places of what's best practices. So as I said, it's developed for intravenous colon cancer. It's a larger molecule, but it still penetrates well. Some of the questions that people have or concerns for are these two things I think you should be aware of. So one is the compounding effect. And so you have to compound Avastin or bevacizumab, and the issues with sterility and compounding and what's available to you limits the ability to provide this medication. So that's an issue that could bring rise, or an issue or a complication you should be aware of. And then some of the systemic side effects. So the data is very, I wouldn't say controversial, but just not conclusive on the systemic side effects. And so if you look at Vision trial versus Marina trial versus the CAT trials, and they're looking at side effects, and then just other studies that have been done in general looking at these 3 or 4 types of anti-VEGFs, the data is inconclusive on are we causing systemic issues. So I think most people agree that there might be some systemic absorption of medications, which is more commonly seen in bevacizumab, but not to the point that it's drastically changing our practice patterns. And so there might be a 2% to 3% chance of increasing hypertensive issues, stroke-related risk factors, and things of that nature in some studies. But I think you should just be aware of that to be able to talk about it for a specific patient encounter. But I don't think it's drastically changing our prescription platforms and how we're offering these medications. But there's different opinions if one causes more than the other, if one shows up in the bloodstream more often than the other. If one is going to show up more often and it's testable, I think it would be pushed out that the bevacizumab is the one, that it's a larger molecule. They've seen more of it show up in the other eye when testing. To see the residual, I can't think of the term, but the residual amount of medication that you find systemically or in another eye when injecting this in one eye. And then the last one, aflibercept or Eylea. So similar FDA approval. This was also just recently FDA approved for diabetic or proliferative diabetic retinopathy, as ranibizumab was. And this one has a longer interval for treatment and is FDA approved after basically 3 courses of monthly injections, to then be able to move out to almost 2 months of injections. This is also what I think would be testable, is that it has a higher affinity for the VEGF receptor, and also treats all pan-isoforms of VEGF-A, B, and placental-derived growth factor. So I think that could be something that would be testable or differentiated between the two. And then this one I think is the Ziv aflibercept is off-label, and I don't think would be testable just yet. So once again, I think if anything, if they're testing specifically this, like I said, this lecture is not on the disease pathologies, but more on the actual agents themselves, if they're going to test on something, I think they're going to test on which isoforms are being tested, what's the differences between the agents, which ones are FDA approved, how long do they last, and then the different thought processes behind monthly treatments, treat and extend, or treat and observe. And so there was a great article recently published in Ophthalmology of January 2019 that shows the clinical safety of efficacy of anti-VEGF therapy specifically for AMD, but it was a good review on the major studies for those with all 4 of these anti-VEGFs. And so probably not high yield for your test, but definitely something to review at some point in the future, where it goes through the different major studies, what was enrolled in which. It's like an 8-page review article. And so if you have time after your test, I think that would be a great one to look at to be able to help differentiate the differences, pros and cons of each. So those are the big 4 anti-VEGFs. Like I said, the other 2 that are in phase 2 trials for their longer acting, and then there's also these talks of reservoir or putting on the surface of the eye or oral medications. I think those are much less likely to ever show up on your test in the immediate future. So for steroids, injectables, the 2 big injectables that are FDA approved that you should be aware of is the intravitreal dexamethasone implant and the intravitreal fluocinolone implant. So these are going to inhibit pathways higher up in the inflammatory chains. They're going to inhibit prostaglandins and inflammation more than anti-VEGF. So like I said, uveitis pictures, obviously you're thinking more inflammatory issues and more likely to give an injectable of a steroid versus the edema or inflammation that comes from choroidal neovascularization, and whereas an anti-VEGF injection might be more applicable to that. So these 2 implants, what's the biggest differences that you should be aware of? So the trade names for this, Ozurdex, trade name for the fluocinolone implant is Illuvien. The Ozurdex is a 6-month duration, whereas the fluocinolone implant is a 3-year duration. And this is non-biodegradable, whereas the dexamethasone implant is biodegradable. The dexamethasone is FDA approved on label for vein occlusions and diabetic macular edema, whereas last I looked, the fluocinolone is only FDA approved for DME. Both of these, the 2 biggest things that you obviously need to be aware of is the cataract and glaucoma risk factors, and which patients are going to have more issues with those, and that would be a contraindication for some patients. Yeah?
I apologize for interrupting, but isn't Ozurdex 3-month duration? Is it actually approved for 6 months?
I believe it is. Yeah, because some of the effect can last out to 9 months for when we put them in, from at least when we counsel. I can double check that, but I believe it's FDA approved up to 6 months, and some residual effect to 3 months. I'll look that up, but that's what I usually counsel, and that's what I thought the last time. I mean, I made this lecture slide about a year or 2 ago, and so unless that's changed, and I haven't changed my clinical practice, but I will look that up in the break, and I'll let you know if it is. So this slide here I thought is just helpful for you to be able to think in your head what's FDA approved for a wet macula, and what you should be thinking of. And so AMD, branch retinal vein occlusion, central retinal vein occlusion, diabetic macular edema, myopic, choroidal neovascularization, histoplasmosis, choroidal neovascularization. What should you be thinking about on your test? What are you likely to be tested on? You're likely to be tested on FDA approved things. So these categories of treatments for these disease processes are high yield. So I think that this is something that you should try to at least work through your head and have some treatment options, why you would use these in which scenarios. So I already went over this, the bird's eye view of pharmacology, and why we use anti-VEGF versus steroids. All right, so some review on learning. What's the answer here? Correct, so pegaptinib. And then pan-isoform. Yeah, so, and then also aflibercept is in that category, but basically pegaptinib is the one that's not pan-isoform, and it is the one that blocks 165. So like I said, it's hard to test on the individual. Like, you're going to get more likely tested on the pathology of these injections, but I think you should have an understanding of some of these basic pharmacokinetics and understanding what we're treating. But I think this is a little bit lower yield, but something that could show up for 1 or 2 questions. And then causative role in macular edema, all of these. So what's a drawback of anti-VEGF therapy? Yeah, so I would agree at C, the relatively short duration, so you have to continue to give these and you're not sure what your endpoint treatment is for depending on the pathology that you're treating. And then which of these is true? Yeah, so this is like, challenging in the sense of the wording of the question. I understand that, but the concepts of what we're testing, I agree. I heard C twice, and so I would say C. And that you obviously you don't want to, any type of medication we're giving to anybody, you want to use just enough to get the effect you're looking for without having side effects. So it's also to point out that, we're trying to do more treat and extend so that we do less injections, that a combination of approaches should be used so that we limit the adverse outcomes and the side effects of the other therapies that we're offering as well. And that's that. Any big questions on any of the 3 lectures from this morning that we have already gone over?